is Hannelie Meyer, and welcome to the second episode of the FIP CPD Bite series on improving pharmacists' education on HPV-related cancers and diseases. By the end of this episode, you should be able to explain how HPV vaccines work and their crucial role in preventing HPV-related cancers. You will gain insight into the real-world effectiveness of available HPV vaccines, understanding their impact on reducing infection rates and cancer incidence. The episode will cover vaccine schedules, eligibility criteria, and recommendations for different populations. Also, you will learn about the safety profile of HPV vaccines and how to address patient concerns and debunk common myths. Let's look at how HPV vaccines prevent HPV infections and related cancers. These vaccines are prepared from L1 structural proteins, which have been purified using recombinant DNA and cell culture technology. These L1 structural proteins self-assemble to form HPV type-specific virus-like empty particles. Thus, when the vaccine is administered, the immune system is triggered to recognize these particles as foreign and an immune response is activated. Neutralizing antibodies are generated that block HPV infection at mucosal surfaces. In addition to the antigen, HPV vaccines contain adjuvants to enhance the immune response. Importantly, these vaccines do not contain any live biological products or viral DNA and are therefore non-infectious. Also, HPV vaccines contain neither antibiotics nor preservatives. The first HPV vaccine was licensed 18 years ago in 2006 with a primary goal of preventing cervical cancer, which accounts for 82% of all HPV-related cancers. All of the available HPV vaccines contain virus-like particles which target high-risk HPV types 16 and 18, responsible for 70% of cervical cancers, 85% of HPV-related head and neck cancers, and 87% of all anal cancers. In addition, the non-avalent vaccine includes virus-like particles which target HPV types 31, 33, 45, 52, and 58, contributing to cervical cancer and other HPV-related malignancies. The quadrivalent and the non-avalent vaccines also protect against HPV type 6 and 11, which cause 90% of anogenital warts, which are benign. So to date, there are 6 licensed HPV vaccines available on the market. This slide provides an overview of the 3 types of vaccines. Important though, always consult the product information for the relevant vaccine to confirm the appropriate age group and dosage interval. HPV vaccines must be stored in the refrigerator between 2 and 8 degrees Celsius. These vaccines are freeze sensitive and should be discarded if frozen. The standard dose is 0.5 milliliters and it is administered intramuscularly in the deltoid region. The HPV vaccine can be co-administered with other non-live and live vaccines as long as separate syringes and different injection sites are used. HPV vaccines are highly immunogenic, with a serological response to vaccination being much stronger than the response after natural infection, which is why natural immunity from an HPV infection may not protect against subsequent infection. HPV vaccine effectiveness is evident from multiple clinical trials and real-world studies, which have demonstrated almost 100% protection against persistent infections with HPV types covered by the vaccine. and a significantly reduced risk of developing cervical cancer and other HPV-related cancers. Long-term vaccine protection has also been demonstrated for at least 10 to 14 years. Furthermore, vaccinated individuals who are exposed to the virus later in life are still protected from the most harmful types of HPV. The benefits of herd immunity have been observed in unvaccinated populations with substantial reductions in HPV prevalence and related diseases. HPV is estimated to cause 5% of human cancers in both males and females globally. Sexually active people are vulnerable to HPV-related diseases and cancers throughout their lifetime, with 4 out of 5 people getting HPV infections. Most of these infections clear up on their own, but persistent infection can lead to certain cancers and other diseases. HPV vaccination, therefore, has benefits for both sexes. Research has also shown an increased burden of HPV-related diseases that affect both males and females. For example, anal cancer incidence and mortality is increasing amongst both sexes. HPV oropharyngeal cancer incidence is significantly higher in males compared to females, and in the USA, the number of males being diagnosed with HPV-related oropharyngeal cancer has doubled over the past 15 years. The WHO recommends the inclusion of HPV vaccination in national immunization programs as part of a comprehensive strategy to eliminate cervical cancer. Vaccination is therefore recommended for girls aged 9 to 14 years before they become sexually active as the primary target population. High vaccine coverage is important, as achieving over 80% coverage in girls also reduces the risk of HPV infection for boys. Catch-up vaccination of girls between 9 and 18 years at the time of vaccine introduction is recommended for increased direct and herd protection. Vaccination of secondary target populations, for example, females aged 15 years or older, boys, older males, and men who have sex with men, is recommended. However, only if this is feasible and affordable. Because immunocompromised people, including those living with HIV, and children and adolescents who have faced sexual abuse, are at an increased risk of HPV-related disease, it is recommended that these individuals are also prioritized for vaccination as part of the public health program. These individuals, regardless of age or antiretroviral therapy status, should receive at least 2 HPV vaccine doses with a minimum 6-month interval, and, where possible, 3 doses. Travelers and health workers are not at an increased risk of contracting HPV infection and should follow the vaccine recommendations for the general population. Current evidence supports the recommendation of a 2-dose schedule for the primary target group from 9 years of age and for all older age groups for which HPV vaccines are licensed. The minimum interval between the first and the second dose is 6 months. Data, however, has shown that a 12-month schedule results in higher geometric mean titers and is therefore suggested for programmatic and efficiency reasons. For multi-dose schedules, the relevant vaccine's product information should be consulted. As an off-label option, a single-dose schedule can be used in girls and boys aged 9 to 20 years. Current evidence suggests that a single dose has comparable efficacy and duration of protection as a 2-dose schedule, and may offer program advantages, be more efficient and affordable, and contribute to improved coverage. From a public health perspective, the use of a single-dose schedule can offer benefits that outweigh the potential risk of a lower level of protection if immunity wanes over time. However, there is no current evidence of this. Since licensure, over 500 million doses of HPV vaccines have been distributed. The vaccine is considered safe and well tolerated, with no new adverse event identified since the first clinical trials. Adverse events following immunization are generally mild and of short duration, with the most common side effects being pain at the injection site or mild fever, while serious side effects are very, very rare. HPV vaccines are contraindicated for anyone who has experienced a severe allergy reaction or allergic reaction after a previous HPV dose or to a component of the vaccine. Data on the safety in pregnancy are reassuring but limited, hence currently not recommended in pregnancy. As a precautionary measure, HPV vaccination should be postponed during moderate to severe acute illness. It is very important to differentiate between anaphylaxis and a stress-related response to vaccination. This can prevent the mismanagement of cases and avoid harm. Clinical signs of a stress-related response, as shown here, can be brought on by anxiety or stress related to receiving the vaccine, such as fear of needles or injections. Now, because fainting is common, individuals receiving the vaccine should be seated and observed for 15 minutes following administration of the vaccine. The WHO reference illustrated on this slide is a very useful guide on this topic. Certain communication strategies are associated with a higher likelihood of vaccination intention. When addressing concerns about the effectiveness and the safety of the HPV vaccine, always be transparent and communicate scientific evidence. Emphasize the personal benefits of the vaccine, which is the prevention of cancer, rather than the benefits to the community. It is also important that HPV vaccination promotion messages should be delivered by trustworthy sources and consider individuals' prior beliefs and attitudes. Patient-centered open dialogue is key for building trust. So this slide illustrates three key strategies for effective personal communication. First, always make a strong recommendation from you as a healthcare provider. This means using strong language in favor of vaccination. Second, use open dialogue, listen to concerns, and never judge. Third, use a presumptive style of communication. This means making a recommendation to vaccinate as a statement which does not require a response. Now, be careful when debunking misinformation. Repeating common vaccine myths in order to correct them with facts may have the unintended effect of strengthening beliefs in the false information. This is because repeated information is reinforced and more likely to get stuck in the mind. Fear-based messages or scare tactics, such as photos of children with vaccine-preventable diseases, should never be used, as this can backfire and increase the perceived risk of vaccine side effects. Not acknowledging uncertainty and risk when communicating vaccine effectiveness can increase vaccine hesitancy. On the contrary, acknowledging that some information is still unknown can increase trust and reduce vaccine hesitancy. So in summary, HPV vaccination is recommended as part of a comprehensive strategy to eliminate cervical cancer. HPV vaccines are safe, highly effective, and recommended for both males and females. Effective communication is essential to address patient concerns about vaccine safety and build confidence in vaccines.